Hello, everyone, and thanks for tuning into my presentation today. My name is Brad Barnett, and I graduated from my anesthesiology residency with Ohio Health in Columbus, Ohio, in June of this year. I just recently started my first attending job with a large private practice in the Cincinnati, Ohio, and Northern Kentucky area. And today I will be presenting to you a case of lung perforation complicating the implantation of a Watchman device. And I have no disclosures. So, ischemic stroke secondary to thromboembolism is associated with significant morbidity and mortality in patients with AFib. The left atrial appendage is the most common site of thrombus formation in these patients. And stroke prevention strategies include both pharmacologic and mechanical occlusion of the left atrial appendage with percutaneous closure devices like the Boston Scientific Watchman device. While there are many known complications of these device deployments, one of the most concerning is perforation of the myocardium itself. And I'm presenting to you today a patient whose status post-CABG with an unclosed pericardial sac, in whom concern developed intraoperatively for left atrial appendage and subsequent lung perforation during Watchman deployment, as noted on the transesophageal echo. This patient was an 81-year-old male. He was a Jehovah's Witness, and he had a significant cardiac history, including coronary artery disease, status post-CABG in 2003, with cardiac cath in 2013 showing reocclusion of several of the arteries. He had heart failure with a reduced ejection fraction of 28%, status post-BiV pacemaker implantation. He presented to the Structural Heart Clinic for a new diagnosis of non-valvular atrial fibrillation that was noted on his pacemaker interrogation, but due to his religious beliefs, he was hesitant to pursue long-term anticoagulation, and thus was deemed an appropriate Watchman candidate at the Structural Heart Conference. In this graphic, you can see the 6 steps as they're graphically represented of the Boston Scientific Watchman procedure. And I would like to draw your attention to step 3, where the access sheath is advanced over the pigtail catheter. And it was during this step that our concern developed. In reviewing this patient's intraoperative course, general endotracheal anesthesia was induced and the patient was maintained on sevoflurane. The right femoral vein was accessed by the proceduralist, and the guide wire was advanced under fluoroscopy. Continuous transesophageal echo was performed during the transeptal perforation and advancement into the left atrial appendage. The patient did cough at that time against the ventilator, and air bubbles were subsequently noted to be entraining into the left heart and crossing the aortic valve, which you can see here in this transesophageal echo video. We were immediately concerned for direct pulmonary communication with the left atrial appendage, the left heart, and so the endotracheal tube was advanced into the right mainstem bronchus, which did result in reduced air entrainment, but not complete cessation. So the decision at that time was made to deploy the device to occlude the left atrial appendage. Flexible bronchoscopy was then performed to evaluate the right lung, and the endotracheal tube was pulled back under direct visualization, and we evaluated the left lung, which was clear and without blood. That time, the patient was switched to a pressure support ventilation mode to help reduce the peak pressures that were being delivered, and ultimately was transitioned to a spontaneous ventilation when able to avoid positive pressure ventilation entirely. The patient did remain hemodynamically stable throughout this entire process. As for the follow-up for this patient, the postoperative cardiac CTA showed that the device was well positioned, and you did note on this particular image of the CT that there is extrav of the contrast along the mid-region of the appendage itself, which is consistent with a small perforation. The post-op course was, however, uneventful, and he was discharged home on post-op day 1. Repeat cardiac CTA in 1 month showed successful closure of the left atrial appendage, and the patient remains on dual antiplatelet therapy with regular cardiology follow-up. Now, for a brief discussion, literature is readily available for patients who develop pericardial effusions and tamponade pathology secondary to left atrial appendage perforation. But in patients without intact pericardial sacs, the literature is very limited. The air entrainment that we noted on TEE was obviously concerning for systemic air emboli, which could have led to catastrophic neurologic sequela or cardiovascular collapse. Other serious sequelae that we considered included hemomediastinum, hemothorax, pulmonary hemorrhage. However, none of these were seen in our patient. Though endothelialization takes weeks to occur with the Watchman device, it has been noted that device deployment appropriately occludes the LAA in many cases and stops active bleeding from the wall of the appendage itself. Thank you for your time today, and I really appreciate you listening to this interesting case. I hope that it sparks some interest and some questions, and maybe provides you with an opportunity to assess a possibility or a possible complication in your future practice. Thanks.
Good morning. My name is Ahmed. I'm a fourth-year medical student at Legal, Louisiana. Today I'll be presenting you a case called Spider, an unusual preoperative diagnosis. So I saw this case in my third year as a medical student at the Appaloosa Hospital in Louisiana. So a little bit of introduction over here. So as we know, Spider is it's defined by a noisy or very high-pitched sound that sometimes we can hear it without even a stethoscope in some bad cases. So the stridor usually happens in the inspiratory phase of the breathing cycle. And it can be really harsh and this offsetting sound in nature that we can tell something is going wrong with the patient. So stridor, there's many different causes of it. It can be primary, caused by congenital defect that happens usually in young newborn infants after birth. It can also happen due to secondary causes such as like pathogenic or diseases, such as like an infection or other causes. So today in this case report, I'll be talking about an 18-month-old female infant that came to our ENT clinic with a complaint of stridor. Our initial evaluation, we can see she had some congenital laryngeal malacia, and at the end, we diagnosed her with a congenital laryngeal web. So to give you a little bit more details about our case, so she is an 18-month-old female. She came to our clinic first with some hoarseness and low-pitched voice, and her parents said that she has some difficulty speaking, and they were concerned about her case. At first, she came at 15 months for initial complaint of dysphonia and trouble speaking, trouble making any sounds or voices, and she had a really raspy voice, which sounded like a strep throat voice, and she also has some throat pain. So at first what we did is we decided to do a flexible laryngoscopy just to get a view of her vocal cords and her performance orifice, the supraglottic, and the nasopharynx, and they all looked normal at the initial presentation. We also decided to treat the patient for a little bit with the sevdavir for her laryngeal malacia, and we gave her 5 ml orally for 7 days. And we also did a strep throat just to make sure to rule that out. It came back negative as we expected. So during her follow-up, the patient came after again for the clinic and her presentation worsened. And she also had the dysphonia and all the general initial presentation, but now she had an additional symptom of hoarseness. And that became the primary complaint that the parents were complaining of. On top of her dysphonia and the low-pitched voice that never went away. So we decided to further investigate the patient. So at first, we decided to look at her family history or any personal history, and there was any findings. We decided the patient was discharged from the hospital after her delivery, and there were no complications. There was no documentation of any respiratory distress after birth or any signs of hypoxemia or cyanosis currently either. She didn't have any trouble breathing. She appeared very developed and well nourished, and everything on her milestone were reached with no problems for her growth and height, her growth and weight as well. We decided to do a physical exam to focus on the nose and the oral cavity, the oropharynx, the neck. Everything looked normal, and there was no anything abnormal findings. So we decided to take it a step further to investigate this hoarseness, and the worsening of the presentation of this patient. So we decided to go with a direct surgical laryngoscopy with a telescope, and we decided to look further a little bit more to see what was going on. We were concerned about more like congenital type of findings that the patient had. So at first, during the scope, we saw that she had a congenital laryngeal web, and it was very prominent at the anterior portion of her glottis. We also saw that she had an omega epiglottis, which surprised us, since it's a very rare to have. We also saw some laryngeal web, and we decided to. I have some pictures over here to show you guys, and the next slide about it. So on the top picture, we can see the laryngeal web. I don't know if you guys can see my point over here, but it's present at the anterior commissure of the glottis on the top region. And for the bottom picture over here, we have a picture of the omega-shaped epiglottis. And the way it's called omega is because it looks like an omega sign, if you guys are familiar. And we can see like the lateral folds of her like glottis are curling inward toward the inside, and that's what gives it the omega shape, as we can see at the bottom two pictures, which is very abnormal and looks different than the normal how it's supposed to be, and it looks more like a V shape that's in the normal cases. So a little bit of discussion to wrap our case over here. So osteitis, as we talked about, it's an abnormal sound that can be caused in the upper airway because of the narrowing that happens there. Hoarseness, on the other hand, is different. It's a harsh sound that could be caused by an issue on the vocal cords, and our patient had both of those due to that congenital defect that she had. They can also be caused by an infection disease process. The most common top etiologies that causes these are angiomalacia, the croup, the foreign body aspiration, and these last two are probably life-threatening emergencies, and they're the worst, and we need to act on them right away. Laryngomalacia is a softening of the tissues that can happen due to congenital birth defects at the larynx or above it at the vocal cords. The most common condition happened to be resolved by its own by 18 months of age, but in our case, it's very unusual because it happened the second time, and it was after that all, and it never self-resolved. If anything, our presentation got worsened with her dysphonia and the throat pain, and the hoarseness. So we decided to refer the patient to a laryngologist to get a surgical management, because especially that her laryngeal web were including at least 1/3 of her anterior glottis, which could be very significant and cause complication further down the road. So we decided to get more referral and to ask for surgical management. So these are my references. Thank you guys for coming to my presentation. And if you guys have any questions, just please email me or reach out to me. Hope you guys have a good day.
So my name is Anish Gupta. I'm a medical student at VCOM, Louisiana campus, and today I'm going to be presenting a case of May-Turner syndrome from an anesthesiology perspective. So we've got no disclosures, conflicts of interest. So we're going to start off, what is May-Turner syndrome? It's basically a compression of the left iliofemoral vein by the right common iliac artery against the vertebral body. It's usually asymptomatic if you have partial obstruction, but progression or comorbid risk factors can lead to deep vein thrombosis formation. It's important to keep May-Turner on the differential when a patient presents acutely with DVT or lower extremity swelling, especially in young women. Some of the risk factors include female sex, especially those who just were postpartum, multiparous, or on oral contraceptives, those that have scoliosis, dehydration, or have hypercoagulable disorders. Gold standard for diagnosis is CT venography with IVUS. And treatment includes catheter-directed thrombolysis with endovascular stent placement, as we'll see in this case. So we had a 60-year-old female with a past medical history of end-stage COPD that required home oxygen. She presented to the emergency room with severe leg swelling. There was Doppler ultrasound ordered, and we saw an extensive DVT in the femoral and popliteal veins, extending all the way through the iliac vein, obviously very concerning. IR was consulted for thrombectomy, and because of the patient's advanced COPD, we also consulted anesthesia for conscious sedation. So the first anesthesia challenge was that the patient had to be prone since popliteal access was required. Prone position requires consideration for different complications to be identified. For example, there's more pressure on interior structures, which leads to an entirely different set of complications than when the patient is supine. You can have pressure sores, you can have postoperative vision loss from inappropriate orbital pressure. You could get lateral femoral cutaneous neuropathy. Severe cases, you can have inappropriate pressure on vital organs of the vital structures of the abdomen, which can cause ischemia, organ failure, and yeah, obviously not good. There's also airway management and CPR issues as access to anterior structures is limited because the patient's prone. So yeah, during the case, we had thrombectomy was performed. A large portion of the thrombus was removed. The severe stenosis was identified in the comic iliac vein, and we made the diagnosis of May-Turner syndrome. The stenosis was then angioplastied with a high-pressure balloon and then stented. So in the images we can see on the left, the contrast sonography shows obstruction of the left common iliac vein. Image 2, you can see the femoral vein thrombosis, and image 3, we have significant improvement in blood flow after the stent was placed. Second main anesthesiology challenge was excuse me, managing the rapid inflow of blood from the left lower extremity after the DVT removal. This could quickly increase right ventricular fluid preload. Thus, it's very important to monitor the patient's vital signs and cardiac output. A non-invasive way to reduce preload is something as simple as positioning. You can elevate the patient's head and upper body to a semi-upright position to promote venous return. A third anesthesia challenge would be a DVT traveling through the stent and entering the pulmonary circulation. This would increase right ventricular afterload and exacerbate right ventricular strain. So studies are kind of mixed on this, but from what I read, moderately dosed positive inotropical agents such as dibutramine and occasionally dopamine are routinely used, even without conclusive evidence. You could also, vasopressors, vasopressor support with norepinephrine can also be indicated. There are inotropic calcium sensitizers like levisomindin that has been experimentally shown to have a beneficial effect in such instances. And then you could use bosentan or another phosphodiesterase 5 inhibitor. The fourth and final anesthesia challenge that we had to consider was management of possible subsequent hypoxia during another pulmonary emboli. So you would suspect PE when expired CO2 is decreased in an acute setting, which would happen due to increased alveolar dead space. The most worrisome outcome is obviously cardiac arrest, which could manifest as PEA, supportive therapy including oxygen, mechanical ventilation, either non-invasive or invasive, IV fluids, and then unfractionated heparin or low molecular weight heparin also to break the clot up. Depending on patient presentation, mechanical thrombectomy or TPA can be indicated. In some instances, you can do secondary prevention with chronic anticoag and cable filter placement afterwards to prevent future recurrence. Thank you for your time.
Hello, my name is Quentin Ryder, a CA2 anesthesiology resident at the Cleveland Clinic, and today I'll be presenting a case on hereditary hemorrhagic telangiectasia in pregnancy and the anesthetic considerations. I do not have any conflicts of interest to disclose. Hereditary hemorrhagic telangiectasia, otherwise known as Rendu-Osler-Weber syndrome, is a rare autosomal dominant disorder characterized by mucocutaneous telangiectasias and arteriovenous malformations. The worldwide prevalence of this condition is estimated to range between 1 in 5,000 and 1 in 8,000 individuals. The pathophysiology of this condition centers on the lack of capillary beds between arterioles and venules, leading to direct contact between these vessels. This is theorized to be due, in part, to an inability to properly recruit smooth muscle cells during angiogenesis. This results in telangiectasias on characteristic locations such as the face, fingers, mouth, and nasal mucosa. AVMs may be present in numerous organs such as the brain, intestines, lungs, liver, spleen, and spinal vasculature. Epistaxis is often the first presenting symptom, and 50 to 95% of patients develop recurrent nosebleeds by 20 years of age. For the average patient, prognosis is good, though severe complications including hemorrhage and paradoxical emboli are possible. Pregnant patients with HHT can have significant disease progression. In pregnancy, nearly every organ system undergoes physiologic changes, which emphasizes the need for careful consideration of HHT's manifestations. Cerebral, pulmonary, and spinal AVMs are especially concerning during pregnancy due to the risk of intracranial hemorrhage, pulmonary shunting, and neuraxial anesthesia, respectively. As a result, anesthetic planning must take into account known and potentially unknown manifestations of HHT when developing the most appropriate approach to providing anesthetic care to this patient population to minimize the risk of life-threatening complications. The case I'm presenting is a 33-year-old pregnant female who initially presented for a pre-anesthesia evaluation. An extensive medical history was obtained due to her diagnosis of clinical HHT. She was first diagnosed in the setting of subarachnoid hemorrhage, secondary to a cerebellar AVM rupture with associated right PICA aneurysm. The patient subsequently underwent multi-staged embolizations complicated by right brainstem infarct and communicating hydrocephalus requiring VP shunt placement. Additionally, 2 vertebral artery aneurysms and 2 left ICA segment aneurysms were discovered, which were all successfully embolized. The patient had 1 prior delivery via cesarean section in 2012. Spinal MRI at that time showed cystic arachnoiditis in the T12 through L1 and L5 through S1 regions. Therefore, spinal anesthesia was foregone and delivery was performed using rapid sequence intubation without complications. The patient's only bleeding history in her last pregnancy was recurrent epistaxis. The daughter from the pregnancy was born with cutaneous vascular malformations on the bilateral arms, but was otherwise asymptomatic. Based off her past medical history, it was recommended that the patient undergo multiple pre-delivery imaging studies to evaluate her current disease status. Most significantly, CT chest was significant for 3 lesions concerning for AVMs, 2 in the left lower lobe of the lung and 1 in the right lower lobe of the lung. Other imaging studies were reassuring. Echocardiogram was performed and similar to her past echo results. MRA brain without IV con showed unchanged postoperative findings related to prior embolizations. The patient was scheduled for MRI of the cervical, thoracic, and lumbar spine, but this imaging was not obtained due to patient noncompliance. Due to the widespread manifestation of these AVMs, multidisciplinary care was utilized for the safest pregnancy planning. In this case, medical genetics, neurosurgery, vascular medicine, cardiology, pulmonology, and anesthesia were involved. Due to patient preference after discussion of risk and benefits, regional anesthesia was attempted. Attempts were made twice to place an epidural catheter. After these attempts were unsuccessful, regional anesthesia was abandoned, and the decision was made to proceed with general anesthesia. For the delivery, some special precautions were employed. Due to the presence of pulmonary AVMs, bubble filters were used for IVs. Subacute bacterial endocarditis antibiotic prophylaxis via 2 grams of cefazolin was also utilized. Patient was intubated atraumatically via RSI on the first attempt. Standard ASA monitoring during the case was used. The patient delivered via C-section, as well as underwent scheduled bilateral tubal ligation immediately after without complication. Operation occurred with 500 cc's of blood loss. The patient was extubated in the operating room and recovered in PACU without issue. The patient was ultimately discharged from the hospital on post-op day 3. Since pregnancy results in an increasing circulating blood volume, asymptomatic HHT patients may suddenly become symptomatic, or the disease may be first diagnosed during pregnancy. Anesthesiologists should consider HHT when a patient has a history of AVMs, recurrent peripartum epistaxis, or other suspicious findings. In those with known HHT, the patient should be advised of the potentially serious risks associated with pregnancies. Clinicians should also be aware of the appropriate management of this condition in the obstetric population. Multidisciplinary care and appropriate pre-delivering imaging and anesthetic planning can minimize the risk of peripartum complications. Current studies of HHT outcomes in pregnancy, mainly 4 studies mostly retrospective, came to several conclusions. The first 2 studies showed miscarriages were found to be no higher in the HHT population than those without HHT, implying the fetus fares normally during pregnancy. However, potential disease complications pose risk to the mother. Secondly, more recent studies emphasize the importance of knowledge of AVMs or a diagnosis of HHT with association of increased survival. The 4th study showed severe complications only occurred in women who are not screened for AVMs. Overall, this case highlights the need for appropriate anesthetic planning to minimize risk from known and unknown AVMs to provide the safest care to the patient. Thank you.
Hello everyone, I'm Peter Shahada. I'm one of the current CA3s at Cleveland Clinic, and I'll be presenting a case report for the management of type 3 protamine-induced allergic reactions with impending RV failure in a patient undergoing mitral valve replacement. The question was to hyperinize or not to hyperinize. Dr. Sandeep Khanna is my staff for the case, and I have no conflicts of interest to disclose. As a background, our patient was a 75-year-old female with a BMI of 26 who presented to us for mitral valve replacement for severe mitral regurgitation. She initially presented to us with dyspnea on exertion and worsening orthopnea that responded well to diuresis preoperatively. And as part of the pre-op workup, TTE and TE evaluation confirmed the presence of severe mitral regurgitation, showing a 4+ MR due to flail. Left heart cath at that time revealed minimal coronary artery disease. A decision was then made for the patient to proceed with a mitral valve replacement. Intraoperatively, standard ASA monitors were established, and invasive monitoring and access included the left brachial arterial line, a right internal jugular 9 French introducer catheter with a 7.5 French PE catheter through that, and a right 20-gauge peripheral IV. As part of the course of the case goes, approximately 10 to 11 minutes after coming off cardiopulmonary bypass, protamine administration was complicated by an acute pulmonary hypertensive crisis where the PA pressures were approaching those of systemic pressures with gross RV dysfunction and dilation noted on TE. Shortly thereafter, cardiac arrest ensued and manual cardiac compressions were initiated. At that time, protamine-induced anaphylaxis or RV air embolism were suspected as our primary differentials. Patient was rehyperinized for potential need of reinstitution of cardiopulmonary bypass. However, medical management with inhaled epoprostenol and IV epinephrine obviated the need to go back on cardiopulmonary bypass. Tryptase levels at the time were drawn and found to be elevated at 37 micrograms per liter, with the cutoffs for our lab at 8.4 micrograms per liter. As part of the discussion, protamine sulfate is a strong polycationic compound that attaches to the acidic moieties on heparin and thereby reverses its action that way. Reports for anaphylactic reactions to protamine have been noted to be in the 0.6 to 1% range. Risk factors for that include previous exposure to heparin with reversal of heparin with protamine, patients who are chronically treated for diabetes with protamine zinc insulin residues, and patients who have allergies to fish or fish products. If a pre-existing known adverse reaction has been documented in the chart, it is critical for the anesthesia and the surgical teams to discuss an anticoagulation plan and a reversal of anticoagulation plan coming off pump. Knowledge of the different types of protamine-induced allergic reactions, their mechanisms, and their management is important for any cardiac anesthesiologist should they arise. So the figure here kind of illustrates the different types of protamine-induced reactions and their mechanisms and their management. So type 1 is the most common type, is a hypertension related to the rapid administration of protamine. and is directly related to histamine release with a transient decrease in systemic vascular resistance. This type is improved with slowing down of the administration and transient support with vasopressors, should it be required. Type 2 is the anaphylactic type responses, and it comes in 3 flavors. Type 2A is the true anaphylactic type reaction that is seen clinically. It's true IgE-mediated reaction with decrease in systemic vascular resistance, increased airway pressures, bronchospasm, flushing, and edema. And that typically responds very well to epinephrine. Type 2B is an anaphylactoid type reaction that is clinically indistinguishable from type 2A. It's also immediate. However, this one is not antibody mediated, it's non-immunologic mediated type of anaphylactoid reaction. Type 2C, is the delayed anaphylactoid type reaction, is insidious in onset and is related to complement activation. It usually, therefore, manifests a little later in the hours to days range. Type 3 is the most feared and fortunately the least common type, and that is the catastrophic pulmonary crisis type with RV dilation, acute pulmonary vasoconstriction with increased pulmonary pressures, and a decreased systemic pressures. It also manifests with non-cardiogenic pulmonary edema and is IgG and complement mediated. Measures to manage this type of protamine-induced reaction is mainly supportive. As part of the discussion, reheparinization and return of cardiopulmonary bypass should always be considered if there is cardiovascular collapse with RV failure following protamine administration. This brings us to the question, should we re-administer protamine to antagonize the effects of heparin for a second weaning attempt if we suspect that protamine anaphylaxis was the cause for the cardiovascular collapse during the first weaning attempt? Case reports have actually showed this to be safe for administration of protamine to antagonize heparin during the second weaning attempt if anaphylaxis was thought to be the cause of the first weaning attempt. The thought process behind that is that the inflammatory mediators thought to cause the acute pulmonary hypertensive crisis would have been exhausted during the first reaction with the first weaning attempt coming off pump. Other alternatives that were described in the literature included bivalirudin. It has no antidote and a half-life of 25 minutes. It's been shown to be safe as an anticoagulant for cardiac surgery with no increased blood loss compared to heparin. However, it's been traditionally reserved for those with HIT antibodies. This type of anticoagulation would have been considered for our patient had we had known that the patient would have reacted this way preemptively, but we did not know that. Several other experimental alternatives have been described in the literature, including PF4, heparinase, and hexamethylpyrin. However, none of them have been shown to be universally efficacious. Take-home points is that reheparinization and reinstitution of cardiopulmonary bypass should be considered if there is cardiovascular collapse with impending or acute RV failure after protamine administration. Differential diagnosis should always include protamine-type reactions, RV ischemia or RCA air embolism if there is evidence of RV dysfunction and failure on TE after weaning off cardiopulmonary bypass. And then lastly, in patients who experience an allergic reaction to protamine, proper documentation in the patient's medical records is crucial with an allergy referral should the patient need further surgical planning with further need of heparin and protamine administration. These are my references, and I am happy to entertain any questions you all might have. Thank you very much.
Hello, my name is Cameron Tobler. I am a PGY2, CA1 at part of Ohio Health at Doctors Hospital in Columbus, Ohio. And this is an interesting case report on the anesthetic management of a hip fracture in a patient with end-stage pulmonary hypertension. This specific surgery is performed at Grant Medical Center, one of the affiliate hospitals, which is a level 1 trauma center in the downtown area of Columbus, Ohio. And so initially, for the background of this case, just kind of provide a little bit of background for the patient and her comorbidities. Initially, we're going to talk about pulmonary hypertension as one of the main factors as the change in anesthetic management for this case. Pulmonary hypertension in elderly patients can create challenges in anesthetic management throughout the perioperative period. This is due to concerns for large hemodynamic swings that are caused by the anesthetics that we use in either neuraxial or even general anesthesia. And pulmonary hypertension is an independent risk factor for morbidity and mortality, with upwards of stated in the literature of 18%. Previous systematic reviews and meta-analyses recommend neuraxial anesthesia over general anesthesia for primary hip and knee surgeries. Although some of that data is a little conflicting, but majority of the time it's recommended. Neuraxial is recommended over general. Not only is the anesthetic management that needs to be evaluated with intense scrutiny of the current guidelines, that surgery for hip fracture should be performed within the first 24 hours, which are associated with better functional outcomes, decreased length of stay, which reduces risk of postoperative complications. So with these types of hip fractures, there's concern that you want to get to the OR as soon as possible, but also want to do it in a safely and timely manner to reduce any risk of morbidity or mortality. And so that's what the anesthesiologists were kind of going off of in determining whether how to move forward with this anesthetic. So she's an 81-year-old female with a significant medical history of severe group 1 pulmonary hypertension. As we know, the different classifications of pulmonary hypertension, group 1 is kind of Group 1 pulmonary hypertension is more associated with inheritable causes, drugs, or connective tissue disorders. So she's probably had this for quite some time. She's on 4 liters nasal cannula, oxygen at home, and it has, on top of that, paroxysmal atrial fibrillation on anticoagulation with CKD stage 3. So many comorbidities that resulted in a fall with an intratrochanteric left femur fracture. She was hemodynamically stable upon arrival to the trauma bay and was admitted to the surgical ICU for further management. Her CT angiography revealed a massively dilated pulmonary artery at 8.9 centimeters. TTE revealed severely dilated hypokinetic right ventricle. So having a lot of backup into the right heart. And patient was optimized prior to surgery. Pulmonology and cardiology were consulted to help optimize her prior to going back to the OR. She continued many of her home medications for her pulmonary hypertension that has been managed for quite some time. She does follow with a pulmonologist as well as cardiology. And prior to the operation, a right IJ CVC was inserted and an A-line was placed. Anesthetic management. After discussion with the patient and family members, they opted to do a neuraxial anesthesia with also some regional anesthesia as well. So a fascial iliacal block was performed preoperatively for additional pain management with 10 milliliters of 0.5% ropivacaine. And this is generally like a field block. Then it was planned to do a intrathecal catheter that was placed while in the OR in a right lateral decubitus position with a paramedian approach at a final location of L3, L4. A 2E needle was inserted at 7 centimeters and CFS was visualized with the spinal needle. Catheter was threaded and left at a skin depth of 12 centimeters. Throughout the case, isobaric 0.5% bupivacaine was slowly titrated to a level of T12. A total of 4.5 milligrams of bupivacaine was used throughout the case, and the catheter was removed at the end of the procedure. So it was not kept in at any time postoperatively. Patient did not experience any intraoperative complications or significant hemodynamic swings. The postoperative course was uncomplicated, and the patient was discharged to an LTAC. Overall, throughout this case, she performed very well. No significant hemodynamic swings, and very minimal dosage of the bupivacaine was needed for her to tolerate this surgery. And with the expeditious process of the orthopedic surgeons to be able to repair this hip fracture in a timely manner provided optimal outcome for this patient. And so I just jotted down some learning points with this case, which I thought were significant. In the setting of severe pulmonary hypertension, the induction and maintenance of general anesthesia creates an increased risk for any surgical operation, especially in elderly patients with multiple comorbidities, as such as she had, with many different comorbidities. But the overall consensus was this hip fracture needed to be fixed promptly. And so, what was the safest way to go about providing an anesthetic that would prevent any significant hemodynamic swings or prevent any risk of morbidity or mortality on our hands? There are some contraindications to the neuroaxial anesthesia in patients with obstructive cardiac pathology when they're relying upon their SVR to help maintain cardiac output. And due to these large hemodynamic swings that neuroaxial anesthesia can create would be detrimental to the patient, such as this one presented. So, concerned with higher dosage of spinal anesthesia or even epidural anesthesia, there'd be concerned a sympathectomy that would cause too much of a hypotensive or large drop in blood pressure. And so with that, the neuroaxial anesthesia creates a sympathectomy that would be significantly detrimental to this patient. So initially, there was consideration for placing an epidural and titrating that appropriately. But after discussion with the anesthesiologist, there was concern of the failure rate of epidurals, and the overall concern that if this failure rate was at any percentage high enough to warrant a concern, we may want to defer to some other type of neuroaxial anesthesia. There are some studies that reported 8 to 20% failure rate among epidural placements, and I think overall we did not want to take that risk. And then there was a concern with this single dose spinal. So if we administered it similar to spinal analgesia or spinal anesthetics, such as in prior to C-sections, where it's a single dose, which we have seen before causes large hemodynamic swings, that would be very detrimental to this patient. So then it was decided to perform a intrathecal catheter to closely and accurately titrate the anesthetic management to her blood pressure and hemodynamic stability. The large hemodynamic swings can truly really affect your cardiac output, your venous return, especially this pulmonary hypertension. There can be a massive cardiac failure or fluid overload in the lungs if anything were to go wrong with a large sympathectomy and hemodynamic swings. Therefore, we use the intrathecal catheter to carefully titrate the anesthetic and reduce any risk of converting to general anesthesia. And that is all. Thank you very much. Very interesting case, and outcome seems significantly positive. Thank you.
My name is Jordan Jones. I'm a fourth-year osteopathic medical student that attends Rocky Vista University College of Medicine in Utah. This is a systematic review and network meta-analysis comparing the sedation strategies for awake tracheal intubation. Before we get into it, let's start out with some trivia. In what country was fiber optic intubation first used? If you guessed England, you are correct. Peter Murphy in England in 1965 used a fiber optic choledocoscope to intubate nasally a patient with Still's disease. Okay, another pimp question. What is the other name for Still's disease? Kudos if you thought systemic juvenile idiopathic arthritis. Okay, alright, let's get back to the presentation. Fiber optic nasal or oral tracheal intubation is one of the techniques available for the management of patients with difficult airways. The procedure can be challenging because it can be uncomfortable for the awake patient. And also the indications to use awake intubation is very rare. A technique is giving no sedation, so just supplying adequate topicalization. However, sedation is noted to reduce patient anxiety, discomfort, and increase procedural tolerance. Here is the timeline of the published practice guidelines for difficult airway management. Guidelines by the ASA for the management of the difficult airway address the use for the awake intubation, stating When appropriate, perform awake intubation if the patient is suspected to be a difficult intubation, and one or more of the following apply. 1. Difficult ventilation with a face mask or supraglottic airway. 2. Increased risk of aspiration. 3. The patient is likely incapable of tolerating a brief apneic episode. Or 4. There's expected difficulty with emergency invasive airway rescue. The guidelines did not address the outcomes of administering sedatives during awake intubation. However, in 2019, the Difficult Airway Society published specific guidelines on practical performance of awake tracheal intubation. A systematic review of airway devices for awake tracheal intubation in adults was also explored in 2021. It is reasonable to suggest that varying sedation strategies exist and require further comparison and evaluation. Randomized controlled trials comparing sedation strategies and awake tracheal intubation were included. We adhered to the preferred reporting items for systematic reviews and meta-analysis, aka PRISMA guidelines. Outcomes of interest are shown on the far right column. The results of the direct and indirect comparisons between interventions were aggregated into a network league table presented by odds ratio with their confidence intervals. We also utilized grade quality of evidence assessment for outcomes. The quality of evidence supporting a superior sedative drug is limited. This is likely influenced by the fact that various sedatives administered using consecutive dosing strategies and safety practices like using supplemental oxygen can be successfully and safely performed in really a wide range of settings and with patients with varying techniques. But we did see no difference between sedation strategies for the following outcomes: need for rescue analgesia, time to conduct fibroscopy, and also overall awake tracheal intubation success rate. Placebo, or using saline, was inferior to all other interventions for the outcome time to tracheal intubation, but the quality of evidence was low. We did notice a significant difference of fewer incidences of oxygen desaturation with dexmedetomidine than other sedatives such as propofol. In respect to oversedation and its consequences, including respiratory depression, airway loss, hypoxia, and cardiovascular instability, it is important to remember you can always give more, but can't always take back. The heterogeneity of awake intubation techniques, skill level, and patient's airway anatomy is a crutch to the analysis. I invite you to review the Difficult Airway Society guidelines for awake tracheal intubation in adults via scanning the QR code on the slide. Thank you for your time and attention.
Hello everybody, my name is Dr. Vince Riley-Dempsey. I'm one of the residents at Doctors Hospital Anesthesiology Residency Program in Columbus, Ohio, and I will be presenting a PowerPoint on the simulation of a high neuraxial blockade in participants after epidural placement. We have no conflicts of interest to disclose. So moving on to the background, epidural anesthesia is a common procedure used in obstetrics to manage pain associated with delivery that has the potential to develop into a high neuraxial blockade. Training in administering epidural or spinal anesthesia is an essential part of an anesthesiology residency program, but it's also important to be able to promptly recognize the signs and symptoms of high neuraxial blockade and to treat it appropriately. So the educational goal of performing this simulation is in two parts. It's to have the junior learner be able to properly assess the patient for placement of an epidural catheter and to obtain informed consent from the patient and to demonstrate the technical proficiency in placing an epidural catheter. And then the second part for the senior learner, it's to create a differential for hypotension after epidural placement and ultimately the identification and treatment of a high spinal. So a brief description of our simulation. So the case involved a 21-year-old female who ends up receiving an epidural anesthesia for labor analgesia, who subsequently develops nausea, hypotension, and respiratory distress after injection of local anesthetic, which then progresses to high neuraxial blockade. The materials we needed for this simulation include standard environment of a labor and delivery suite on the OB/GYN floor, as well as epidural cart and airway supplies. We also used a Laerdal SimMan 3G Plus mannequin, an M43B the Kyoto Kagaku Lumbar Puncture Simulator 2. The responses after the simulation in terms of feedback were collected in the form of a REDCap survey immediately following the simulation debrief. Questions in the survey evaluated the learners and the observers' comfort with different aspects of management of high neuraxial blockade. So there are several learning points to be obtained with this simulation. First, you want to be able to discuss the risks and benefits of epidural catheter placement and obtain informed consent. Next, you want to be able to properly assess a patient for placement of an epidural catheter and ensure proper monitoring is being performed. You want to demonstrate proper sterile technique and competency in placing an epidural catheter. You also want to be able to identify the signs and symptoms of high neuraxial anesthesia. Furthermore, learners also should be able to demonstrate interdisciplinary collaboration with other specialties, in this case mainly between the OB-GYN team and with the anesthesiology team. You also want to be able to demonstrate technical ability to perform emergent endotracheal intubation. And finally, you want to be able to analyze critical decision-making in a pregnant, hemodynamically unstable patient with a difficult airway. So the critical actions in epidural placement, for this case, we want to be able to evaluate the patient prior to procedure, including doing a physical exam, the airway exam, reviewing any pertinent labs, in this case, having at least a type-in screen and a platelet count. You want to also be able to discuss the risks and benefits of epidural anesthesia with the patient and properly obtain informed consent for the procedure, as we discussed prior. The learner should also be able to check that the blood pressure monitoring is set to Q3 minutes. You want to be able to describe and demonstrate proper patient positioning for epidural placement. You want to demonstrate correct sterile technique in placing an epidural. And then finally, the learner should be able to assess the patient after placement for level of blockade and or for any abnormal findings. So the next step in critical actions is management of high neuraxial blockade. So this is more for the senior learner. In part 1 is being able to recognize early signs of hypotension, bradycardia, paresthesia, being able to discontinue the epidural infusion upon recognizing these signs. And then upon discontinuation of the infusion, appropriately administering any vasopressors, in this case including ephedrine and phenylephrine, as well as a fluid bolus. Learners should be able to request help in a timely fashion from the OB-GYN team. They should also, at this point, administer 10 mics and a bolus of epinephrine to treat the refractory hypotension and bradycardia, and then ultimately progresses further and further until ultimately the learner should recognize to sedate and intubate the patient, in this case with a 6.5 millimeter ET tube to account for upper airway edema and to attach an ambu bag. So this is a busy slide, but in the ideal scenario, the learner enters the room and then finds the patient in mild distress with labor contractions. They'll perform a complete assessment of the patient, appropriately consent them for placement of an epidural. Upon starting the epidural pump, the patient will describe an abnormal sensation in their legs, become hypotensive bradycardic. The infusion pump should be discontinued, start IV fluids, and start pressors. The patient's cardiovascular status doesn't improve, their oxygen saturation begins to decline. Then the patient will notify the learners that it's difficult to breathe and they feel very weak before becoming unresponsive. At this point, the learner should notify the OB-GYN team as well as the anesthesiology team. And then an epinephrine bolus should be administered and the learner should be prepared to sedate and intubate the patient. And then subsequently, an ambu bag should be utilized and connected to a source of oxygen while preparing the patient for transport to the OR. In our results, we submitted anonymous surveys via REDCap. To date, there have been 6 total responses. Answers were qualitative, typically ranging from strongly disagree to strongly agree. Most responses regarding confidence in one's own procedural abilities range from neutral to very knowledgeable. Responses regarding initial confidence in the ability to recognize warning signs and symptoms and management steps of high spinal range from neutral to agree. And then responses regarding acquiring new knowledge, as well as intent to apply this information, range from agree to strongly agree. And so finally, where to go from here? Mainly our goals would be to obtain more participants at any and all levels of training and from different services in this situation, and maybe more from the obstetrics and gynecology team to develop a simulation that can be utilized at a broader level, and then finally refining the simulation. In this case, it's more clarifying participant roles, who's doing what in this simulation. That's the end of this presentation. Thank you for listening. Have a good one.
Hello, my name is Ajay Matal, and I'm excited to be here to present our findings related to the feasibility and acceptability of virtual reality interventions to reduce perceived pain and anxiety for patients who are receiving a brachial plexus block procedure. Now, virtual reality is an emerging technology that's being explored in a number of different use cases. And in particular, there's been an interest within my research group to explore virtual reality in medicine and how it affects patients' experiences during these relatively minor procedures. So when we're looking at a brachial plexus block, it's a routine type of procedure that's being performed where there's a local dose of anesthetic that is applied in your neck or above your collarbone, and it can be used often with patients coming in with broken bones or broken arms to alleviate the pain associated with that complaint. And what this study was really looking to do is be a pilot study to assess whether this is a feasible thing to do in practice, and in particular, the use of virtual reality as an adjunctive therapy to alleviate some of the physical and psychological symptoms that patients who are receiving a brachial plexus block have. So specifically, we're looking at that effect on the pain perception before and after the medical procedure is performed. And similarly, we're looking at that perceived anxiety before and after. And in doing this project, we have a control group where the patient's just being exposed to the standard of care, and then also a group randomly selected where patients are experiencing the virtual reality during this process. So of course we have those two different study groups, and we were able to enroll about 40 patients into the study. And although the pain aspect is not prevalent in either of these patient populations due to the block, there is still the fact that you can see the injury that causes the anxiety and the feelings of pain and the perception of pain rather. So by using the virtual reality, we're looking to assess how those patients are at baseline, and we're doing a couple different things to look at that. One thing we recorded in the patients is also their vitals, which are routinely taken in these cases. So we're looking at their blood pressure, their heart rate, the rate of respiration in the participants in both the virtual reality as well as the control group. And similarly, we have a numerical rating and surgical fear questionnaire that we use as a standardized way to gauge how patients are feeling with regard to those procedures. Similarly, and going into the feasibility aspect of this project and this pilot study, is we assess the time it took to perform the respective procedures in this case, and whether there was a difference between the two groups. And outlined below, a little lower on the methods, is just an example of that 1 to 5 kind of scale we use related to procedural anxiety questionnaire. So our preliminary results, as this is still an ongoing trial, but within the 40 people that we've so far enrolled, we've noticed that there has been significant improvements post-intervention in the VR group, were demonstrated with regard to the perception of pain, the anxiety and the stress, along with some quantitative measures, related to the vitals that I was discussing earlier. And we feel like these findings are indicating that there could be a benefit to the patient and their overall experience going to the ER and a surgical center that performs these types of brachial plexus blocks on a routine basis. So our investigation encourages the utilization of VR intervention within these patient blocks, and we feel that future research that can go into a little bit more depth about the types of experiences patients can receive in the virtual reality could even be potentially more beneficial for some of the cases. So attached in the different figures is a demonstration of some of the technology we're using. So for this project, we're using an Oculus Quest 2 device. And each of the patients enrolled into the experimental group were given a little tutorial along with the research assistant who's stationed there in regard to how to use it. And figure 2 as well as figure 3 can show examples of the different experiences that the patients were engaged in during their procedures to get a sense of kind of what they were viewing while they were being worked on. So in conclusion, these findings of this novel technologic intervention should be investigated further into different patient populations to assess their effectiveness in reducing the perceived pain and anxiety during the surgical interventions, especially when the patient is awake during them. And future studies can even go more into behavioral aspects, such as behavioral modifications that can occur with the use of virtual reality and augmented reality technologies to encourage better habits, as well as the gamification of different therapies that patients could be prescribed to do at home in terms of rehab and recovery. So what's exciting is that there is a great avenue for the use of virtual reality in anesthesia, and we're excited to explore the different applications as we advance this research study. Thank you for your time.
All right, what we're going to do now is we're going to open it up for questions for all the presenters. They're going to be on here virtually, so you can physically ask the question. We have a microphone we're going to take around. You need to speak pretty loudly into that so that these authors can hear your question.
Now, this question is for Peter Shahada. And that question would be, I may have missed it in the presentation, but you talked about the different considerations for reversing the reheparinized patient. And I was curious as to which one you used. Did you go ahead with the protamine again, or go ahead?
Yeah, so we did go ahead with the protamine. The thought process was, according to literature search that we did kind of in the short period of time, if a patient has experienced a protamine reaction during the first weaning attempt, usually the inflammatory responses that occur with the first weaning attempt would not recur during the second weaning attempt because all these mediators would have been exhausted. So yes, protamine was used the second weaning attempt, kind of slow administration, and we kind of slowly gave a test dose and administered the rest of the protamine over a prolonged period of time as compared to the first time. But we did not see the reaction the second time, and we had kind of the vasopressors and the inotropic support necessary should the patient had experienced any sort of reaction coming off. Thank you very much for the question. That was actually a concern that we had coming up the second time, and whether we should reverse the patient with additional protamine or not. So we kind of discussed it with the surgeon and decided that we're going to give a small test dose and see how the patient reacts to it.
I have a question for Dr. Quentin Ryder. Okay, my question is with this lady with the telangiectasias in pregnancy, it was attempted, an epidural was attempted twice in this lady. Was there something about her that it wasn't able to be gotten in physically, or what was going on there?
Yeah, so that's a good question. So for both of the attempts, and obviously this was after the risks were discussed with the patient who really wanted to go forward with it, the loss of resistance was obtained relatively easily, but when the epidural catheter was attempted to be threaded, it would hit resistance once it got to the end of the needle. So that's why they got lost the first time, attempted to thread the catheter. They were unable to thread it. They tried at a different level, and again, we're still unable to thread the catheter. So rather than try to force the catheter in the setting of the patient being non-compliant with her pre-delivery imaging screening for possible progression of her AVMs in her spinal canal, it was kind of presented that general anesthesia was the best option.
So you think that might have been due to progression that you didn't know about? Why they couldn't get the catheter in at two separate levels?
Correct. It is possible. Of course, without new imaging study, you can't really say for sure, but I think that was the major concern.
Okay, you guys are a little bolder than I. If the patient hadn't done her imaging, I probably would have said, no way, Jose. Thank you.
No problem.
Any other final questions?
I don't remember the last presenter's name, so I apologize.
Hi, how are you?
We're doing great. Thank you.
Great.
You mentioned you use the Oculus system,
Yes.
virtual reality system. Have you and your team talked about, perhaps some groups are doing this, but bringing that device to the patients on loan to create this so-called, perioperative surgical home for patients as they, watch a video for 3 minutes and simulate what the experience would be being rolled in, having a pre-oxygen mask, etc.
Yeah, I think that's a fantastic suggestion. When we were approaching this iteration of the project, looking at virtual reality for brachial plexus, blocks, we're looking to do it, patients that are undergoing that type of procedure. Pre-procedurally, we have a different iteration of the project where we're applying it as a pre-op tool for patients who are about to go under cardiac ablation. We were finding it helpful, but I think there's a lot of potential kind of exploring that and just trying to see how virtual reality can be used as a tool to bridge for patient education, as well as what we're doing for pain perception and anxiety.
Okay, if there aren't any final questions, thanks everyone for your attention. Authors, presenters, thanks so much. You guys all did a fabulous job and really increased our knowledge. So I give you a lot of credit. It's hard doing this virtually, but it went pretty flawlessly. And again, thanks so much for all the hard work that you did. Give them a round of applause.